Okay, this is Andrew Wolf, and in this video I am going to talk about the oxygen-hemoglobin dissociation curve. Now, this is often a topic that is sort of complicated to understand, and hopefully this video will make it very sort of intuitive for you. And I think one of the things that makes it difficult for particularly nurses to understand is because it's somewhat counterintuitive, because we tend to focus on just the oxygen saturation number, and when it's low that's a bad thing, and when it's high that's a good thing. But when we talk about the oxygen dissociation curve, it becomes a lot more complicated than that. So hopefully that when I talk about through this video, this will give you a different perspective on what oxygen saturation means when we measure it at the arterial level, or put it on an oxygen saturation probe on someone's finger. So let's talk about what oxygen saturation means to begin with. So over to the left side here, I have a little picture of a hemoglobin molecule, and obviously that's going to be inside a red blood cell, and that red blood cell is going to be floating around inside a capillary. Now, this red blood cell is surrounded by oxygen particles, and depending on what the concentration of oxygen particles are in the blood, the oxygen particles freely dissolve through down their concentration gradient through the red blood cell membrane. So the plasma concentration of oxygen particles are going to be very close to the particles within the cytoplasm of the red blood cell. So the much of this oxygen is going to be carried, in fact the majority of it is going to be carried on receptors, little protein receptors that are part of the hemoglobin protein. Now remember, in our previous video when we talked about the partial pressure of gases, we talked about the normal partial pressure of oxygen in our arterial bloodstream and our capillaries as being somewhere around 110. Now, when we have a normal PO2 of around 110, our saturations are usually going to be about 95. Our oxygen saturation is going to be usually about 95 to 98%. So that means if we have here in our diagram a partial pressure of oxygen of about 110 millimeters of mercury, then about 95 to 98% of these receptors are going to be filled, but there's going to be occasionally an empty one. In fact, about 2 to 5 out of 100 of the receptors on hemoglobin are going to be empty. Now remember, this red blood cell is going to be filled with literally thousands of hemoglobin proteins. And I'm just showing you one. Now what's interesting is, as this partial pressure drops and we have a lower concentration of oxygen in the bloodstream, then some of these oxygens are going to sort of fall off of the hemoglobin and detach from the hemoglobin, and this just happens naturally because it's a very loose, relatively loose and reversible bond. So as we move to the left on this oxygen hemoglobin dissociation curve, and we get down to a level of oxygen concentration that we might see in the tissues. Remember, this level is normal in arterial blood and the arterial side of capillaries, but if we get down into the tissues, the oxygen level is going to be lower because the tissues are using the oxygen. So down in the tissues we may have a oxygen saturation of around 80%. And actually, to make it more realistic, the average oxygen saturation within the tissues is around 70 to 75%. And this is again the average of the entire body. Some tissues in the body are very efficient at extracting all available oxygen. So the cardiac myocytes, for example, oftentimes will get partial pressures down to 10 or 15, and oxygen saturations of about 20 or 20%, 20 to 25%. So in the tissues, we're going to be looking at this part of the curve of the oxygen hemoglobin dissociation curve, and on this part of the curve, much of the oxygen is going to drop off of the hemoglobin as the partial pressure decreases. Now, before going on further, I want to call your attention to things for those of you who have worked on the floor. Most nurses pay attention to this part of the curve because this is what we can see on our little oxygen sat probe, where it says, the patient's saturation is 95%. But for the tissues, this is the important part of the oxygen hemoglobin dissociation curve, because this is where the oxygen is falling off of the hemoglobin and into the bloodstream, and then from the bloodstream into the tissues. And it's the tissue supply of oxygen that is critically important and of most importance. So I want to put that in your mind as we start to talk about how the oxygen hemoglobin curve can shift from one side to the other. Okay, now the first thing that I want to talk about is a right shift in the oxygen hemoglobin dissociation curve. And what a right shift means is that if you look at sort of the most perpendicular part of the curve, somewhere in the middle of the curve, if we shift that part of the curve to the right, that's called a right shift. So a right shifted curve, you're going to have sort of the same shape of curve. It's going to be a sigmoid curve, and it's going to look something like that, and the two ends sort of come back together. And notice here that it's this middle part of the curve that has the greatest difference between a shifted curve and an unshifted curve, and that has very great significance. Okay, so what does it mean when we are shifting the curve to the right? That means there are conditions in the body that are causing oxygen and hemoglobin to have looser binding. Okay, so a right shift is loose binding. So basically what we have here, you can sort of picture it, and it's probably not very far from this in reality. So there are chemicals in the body, or conditions in the body, that actually change the shape of these, the conformation of these binding surfaces of the hemoglobin molecule, so that they're sort of have a wider conformation. And this wider conformation makes it so oxygen can still bind, but it's going to be bound a lot looser. Okay, so it's still binding there, but it's much looser. So what does loose binding mean? Well, it means that at the top of the curve here, you're going to have a lower oxygen saturation corresponding to the same partial pressure of oxygen. Okay, so instead of having a normal sat of 95% here, if we've right shifted the curve, your normal saturation for a PO2 of 110 or so is going to be maybe 90%, right? So what's happening here in the bloodstream? Well, so say we have here our normal PO2 of 110 or so. What would happen is, because these receptors are looser and have a lower affinity for oxygen, they're going to be less likely to have binding with oxygen. Okay, so what causes loose binding? What causes these areas of the hemoglobin protein to become looser? Well, there are four different things that are commonly thought about, and one is um, increased uh, increased acid or hydrogen ion concentration. Now, this is where it becomes a little confusing to remember because increased acid equals decreased pH, right? So a normal pH is 7.35 to 7.45 in the blood. So this would be, a decrease to a pH of maybe 7.25. At the same time, increased carbon dioxide concentration. So again, a normal carbon dioxide concentration is around 35 to 45 millimeters of mercury, a partial pressure. And if we increase that to, say, 55 millimeters of mercury, then that would shift the curve to the right. Increased temperature. So if a patient has a fever, so say a temperature of 38.5 degrees Celsius. And then the other thing that can do it is increased BPG. And just keep that in your mind, and I'll talk about BPG in a few minutes. So all of these things will shift the oxygen hemoglobin curve, dissociation curve, to the right. And again, this kind of looks bad because if you look at the patient's oxygen saturation, it's lower than it was otherwise, but it's lower for the same partial pressure of oxygen. Now, what's interesting here is if you look at this part of the curve, remember how I said that this part of the curve has more clinical significance because this is where the oxygen is getting supplied to the tissue? Well, at this part of the curve, the oxygen dissociates much easier and gets delivered to the tissues easier because of a loose binding. So, as oxygen levels drop, as the blood starts to work its way through the capillaries in the tissues, the oxygen drops off of this hemoglobin very, very easily and much quicker than it would if we didn't have loose binding. Okay? So in a way, this number up here does not reflect the reality of what is going down here in the tissues, because the tissues are getting the oxygen that they need much more efficiently. So you don't need as high a level of oxygen saturation at the arterial end. Okay, so what happens when you shift the curve to the left side? If you shift the oxygen hemoglobin dissociation curve to the left side, you're going to end up with tighter binding, right? And all of this is going to be exactly the opposite. So we're going to have tight binding, and this tight binding can be caused by decreased acid or increased pH, so a pH of maybe 7.55, or a CO2 moving down to 25, or a temperature of maybe 35.5, or decreased BPG. So, and when will this happen? Well, this will happen in states of alkalosis. So it could be respiratory alkalosis or metabolic alkalosis, or in patients with hypothermia. Now, the interesting thing that goes on here is you sort of have a false sense of security because you might have a PO2 that is way down here, the patient might actually be hypoxic, and you have a PO2 that's maybe way down here in the 70s, and you have a false sense of security because even though your PO2 is way down in the 70s, you may have an oxygen saturation of 92% or above. And so the oxygen concentration of the blood, the partial pressure of oxygen in the blood is actually quite low. And to make matters worse, down here where the tissue is being the oxygen is being delivered to the tissues, the oxygen is actually very tightly bound to the hemoglobin. So even when the oxygen concentration becomes quite low, it's going to be clinging to this oxygen very, very tightly. So even as the PO2 level drops down to the normal 40 or 50%, the oxygen is going to cling onto this hemoglobin, and very little of the oxygen is going to be available to be delivered to the tissues. So a state of alkalosis or hypothermia can give you a false sense of security because your oxygen level in your oxygen saturation reading may look just honky-dory, but the tissues, on the other hand, are starving for oxygen. Now I wanted to talk about a case study. So this is a 41-year-old patient that was being treated for acute leukemia with chemotherapy and developed neutropenia. Because of the neutropenia, ended up developing pneumonia and becoming septic. Now, those of you who aren't familiar with sepsis, it's very common with sepsis because of poor perfusion for patients to develop a metabolic acidosis from an elevated lactate level. So it's otherwise known as a lactic acidosis. Now, in this patient's case, the arterial blood gas looked like this. The patient had in their arterial blood had a pH of 7.25, which is low, meaning that they are acidotic. A PCO2 of 55, which is above the normal 35 to 45, so they were hypercarbic. The PO2 was a little on the low side, 75 partial pressure of 75 millimeters of mercury, and again normal is 90 to 110 or so, and an oxygen saturation level of 88%, which was also a little bit on the low side. So let's kind of plot this on the oxygen hemoglobin dissociation curve. So we have here, this is 80, not 90, so kind of put a 90 in here. The 90 would be about there. So we have, our 75 marker is about here. So I'm just going to sort of plot this. So the plot here on this person's graph is going to be about here. So their sigmoid curve is going to look something like this. Yeah, it's not the greatest curve, but you get the point. Now, this patient is going to have a right-shifted oxygen hemoglobin saturation curve. And how do I know that? Because I know that patients that are acidotic and patients that have hypercarbia are going to have a right shift in their oxygen hemoglobin dissociation curve. So the normal curve would have looked something more like this. Okay, so this patient has shifted to the right. And this is because the patient has looser binding on the oxygen receptors of the hemoglobin. So here's the hemoglobin molecule, and we have looser binding. So again, what does looser binding mean? It means that for the same partial pressure of oxygen, fewer of these hemoglobin oxygen receptors are going to bind with the hemoglobin. So that results in a low saturation level. So this patient's saturation is 88%, right? So that looks kind of bad clinically, and that would worry most nurses, depending on the patient's history. So, the patient's probably going to be put on some oxygen or whatnot. But, it may be worrisome, but it actually isn't as bad as we think it is because of what's going on at the tissue side of the oxygen hemoglobin dissociation curve. Remember, this is sort of all happening at the arterial end. Now, when we travel down to the tissues, um, the tissues are going to start, some of this oxygen is going to start to move from the capillary into the tissues. And as it does, the partial pressure of oxygen is going to begin to drop, right? And because these receptors are so loose, they're going to unbind much more readily, so more oxygen is going to be available to be delivered into the tissues. So even though the patient is hypoxic at the arterial level, they may not be so hypoxic at the tissue level. So their oxygen delivery is actually very good in spite of the low saturation at the arterial level. So in a way, these numbers make things look worse than they are at the tissue level. Okay, so let's look at, I want to talk a little bit about BPG. BPG is, and I'm not going to write this all down, but BPG stands for a chemical called bisphosphoglyceric acid. Now, BPG is a chemical that exists in and is synthesized in our red blood cells. So, and it's interesting because BPG, the more BPG we have, the looser the binding is on our hemoglobin. Now, what's interesting is BPG seems to be a chemical that our red blood cells use to adapt to chronic hypoxia. Chronic hypoxia causes the red blood cells to create more. Here, chronic hypoxia causes the red blood cells to create more BPG. And again, more BPG is going to cause looser binding in the hemoglobin, so that again the oxygen saturations are going to look worse on the arterial end, but the oxygen delivery to tissue is going to be much better. So this is a way that our bodies use to adapt to high altitudes and other conditions of chronic hypoxia, like COPD. And those of you who have worked in medicine for long enough know the chronic COPDers that have arterial oxygen saturation sometimes of like 86%, and they feel just fine. Any other patient with an oxygen saturation of 86% is going to be feeling lightheaded because of poor delivery of oxygen to the brain. But there are people with COPD that have chronic hypoxia that do just fine with an oxygen saturation of 86%. And that is, number one, it looks worse than it really is because it corresponds to a partial pressure of oxygen that isn't all that far from normal. It may be like 75 or 80 millimeters of mercury. Whereas with a normal healthy person, a oxygen saturation of 86% is going to correspond to a PO2 of maybe around 55. But the main reason is that the oxygen that is available is easily unbinds from hemoglobin and is distributed to the tissue. So again, this oxygen very easily unbinds because of the loose binding and is delivered to the tissues. Okay. So that is BPG is the main reason why you see this observation where people with COPD can do just fine with an oxygen level of like 86%. And the same is true with people who live in the high Himalayas up at 16,000 feet. They're also going to have lower oxygen saturation levels at the arterial end just naturally. So, a nice healthy Sherpa guide may have an oxygen saturation of like 88% with their PO2 of a normal PO2 of 105, but the oxygen that is available is going to be delivered to the tissues very, very easily, and this is all because of elevated levels of BPG that's being synthesized by the red blood cells in response to this chronic hypoxia. Okay, so that is my explanation of the oxygen hemoglobin dissociation curve, and please let me know if you have any questions.